Okay. මම අවසාන වසරේ වෛද්‍ය ශිෂ්‍යයෙක්. මම වාව පරීක්ෂා කරලා බලනවා මගේ විභාගෙට. කමක් නැහැ පරීක්ෂා කරාට. මම වාව පරීක්ෂා කරලා බලන්නේ මේ ප්‍රසවහන අය වෛද්‍යවරු දෙන්නගේ ඉස්සරහ අපිට. හරි? කැක්කුම කොහෙද තියෙනවද මට කලින් කියන්න. හරිද? Okay. අත් දෙක දෙපැත්තෙන් තියාගන්න දරුවෝ. So positioning is important. The lady should be lying in supine. Hands should be on either side of the abdomen and legs should be kept straight. Right? So positioning you have to do by yourself. You can't expect the attendant to do it. Then you are supposed to be having a chaperone as well. So I have an attendant here. Then after positioning, exposure is the next step. So exposure also you have to do it by yourself. Mama, you have to first tell what you are going to do and get her verbal consent. Mama, bada balanna me aduma ulta karana. Hari? So you have to roll it and expose up to the cipistern. Right? Mama saya ulta karta kamak නැද්ද? Hari. So you have to, most women they like to the underskirt to be taken up. You can either take it down, up or down, whichever way you like, right? So up to the cipisternum, it should be exposed, and then you have to expose up to which point? Pubic symphysis, not mid thigh. Yeah, it's very important. Amma thattam poddak ussanna. So from both aspects you have to take it down. Hari, දැන් කකුල් පල්ලට. හොඳයි. හොඳට ඉන්නවා. You have to always talk to the mother. You have to talk to the mother and keep her at ease. Right? You have to make her feel very comfortable throughout your examination. Right? කතා කරලා තමයි කරන්නේ. And I of course I prefer to keep one hand on the shoulder so she feels more comfortable. Right? Alright. Okay. So then next point is inspection. On inspection, now there in this abdomen is asymmetrically distended, where the distension is more towards the lower half of the abdomen and it is more prominent on the right lower quadrant. Right? So then there are the surgical scars. There is a suprapubic transverse surgical scar. You have to point it out and show. There is a suprapubic transverse surgical scar. Then the length you can calculate. 2 fingers is 3 centimeters. 1, 2, 3, 4, 5. 15 centimeters in length. I have taken a history, so I know that this scars indicating of the previous 2 cesarean sections. So these scars are possibly caused by the previous 2 C-sections. Then there's a intraumbilical transverse incision scar, and then there are 2 0.5 centimeter size lateral scars which are indicating of the previous laparoscopic surgery that she has undergone. Then the umbilicus is inverted. There is no Sister Joseph nodule. Right? Okay. ඔළුව උස්සලා අම්මා කකුල් දෙක දිහා බලන්න. හරි. නෑ. කොහොම ඉන්න කකුල් පල්ලයට කරගන්න. කහින්න බලන්න. හරි. There is no visible cough impulse. ආයි කහින්න බලන්න. There is no palpable cough impulse. Right? So you have to look for inguinal hernias. Then now you go into palpation. Okay, so palpation, first you have to do the superficial palpation. So on superficial palpation, before you start you say amma mama දැන් වගේ බඩ අල්ලලා බලන්න. මොහේරි කොහේරි කැක්කමක් තියනවද? නැහැ නේ. හරි, කැක්කම ආවොත් කියන්න ඕනේ මම එතකොට එතන බලන එක නවත්තන්න. හරි? පහසුවෙන් ඉන්න. හොඳට උස්ම ගන්න කට ඇරලා. හරි. Ask her to breathe. So she is more at ease. And on my superficial palpation, I'm mainly looking for the tenderness. But she has such a big mass, which is prominent even on superficial palpation. So superficial palpation, I can feel a mass in the lower half of the abdomen, right? But rest of the abdomen is soft and non-tender. Okay. Now you have to define whether this mass is intra-abdominal and whether this mass is which part of the abdomen this mass is arising. How you do that is you keep your hand on the mass. Amma ඔළුව උස්සලා කකුල් දෙක දිහා බලන්න. Right. ඔළුව පල්ලයට දාන්න. When the anterior abdominal wall muscles are contracted, the mass is less prominent. Therefore, this mass is arising from the abdominal cavity. Right? Then I can't get below the mass. However, I can get above the mass. Therefore, this mass is arising from the pelvis. Then the sides you are going to demarcate by, you start from the episternum, you come down, right? So the upper board of the mass is at the umbilicus, therefore it is equal to a 20-week gravid uterus in size. Then you come from either side, right? Do it very gently, right? So this is deep palpation where you're feeling the mass and you demarcate the size, right? Okay. So the mass is occupying the lower half of the abdomen and is more towards the right side. Its margins are well demarcated. It has a bosilated surface because there are lumps on the mass. So probably this is caused by a fibroid uterus. Margins are well demarcated. Its surface is bosilated, right? And it is firm in consistency. It is mobile in the horizontal axis. However, it is not mobile in the vertical axis. Right. Okay. Then now I have commented about the mass that is arising from the pelvis. Next is I have to look for the liver, spleen, and the 2 kidneys. Then I have to look for free flow. There's an important point when you're palpating, right? When you're palpating, superficial and deep palpation, when you keep the hand, you have to look at the hand. Then you have to look at the patient's face, right? So this is how you do it. You look at the hand and you look at the face, right? When you keep the hand on the abdomen, you look at the hand. When you're pressing down, you look at the face. So you know whether you're hurting the patient or not, right? So that should be synchronized always. Understood? Right. So now I'm going to look for the liver. How you look for the liver is you start from the right iliac fossa. You ask the patient to breathe. When she's breathing in, you press in. When she's breathing out, you let go. Right? So the lower board of the liver will be hitting on your fingers. So her liver is not enlarged. Let's say if there was a enlarged liver, then you will say, sir, I can feel a mass in the right hypochondrium. I can't get above the mass. It has a smooth margin or a irregular margin, right? And its dullness is continuous with the liver dullness. And there are no resonant bands overlying the mass. Therefore, it is the enlarged liver. That's how you permit. Then you have to look for the spleen. How you look for it? You start again from the right iliac fossa. You ask her to breathe, then palpate. Amma ගැඹුරු හුස්ම ගන්න. ගැඹුරු හුස්ම ගන්න. ගැඹුරු හුස්ම ගන්න. මගේ පැත්තට චුට්ටක් හැරෙන්න. හරි. ගැඹුරු හුස්ම ගන්න. හරි. හොඳයි. අනේ කෙලින් අතරින්. So the spleen is not enlarged. If it is enlarged, how you are going to say is there is a mass arising from the left hypochondrium which is extending down the axis of the 11th rib. Okay? Then it moves with respiration. There are no resonant bands on top. This is the enlarged spleen. Then you are going to look for kidneys. Kidneys, you look for palatable kidneys, right? You keep your lower hand on the loin and see if it is palatable. She is obese, so most probably won't be able to feel it. If the kidneys are enlarged, how are you going to define it? You will say, I can feel a mass in the right lumbar region, right? I can get above the mass as well as I can get below the mass. It has a smooth surface and it moves with respiration. The mass is palatable, therefore it is a palatable kidney and the kidney is enlarged, right? You are done. So we have completed the palpation now. Next is you go for percussion. So percussion, first you look for flank dullness. So you can see the resonance, you can hear the resonance, so you look for flank dullness. If there is flank dullness, then you have to look for horseshoe dullness, right? So you percuss this way. If there is horseshoe dullness, you are going to look for shifting dullness. how do you look for shifting dullness? You ask the patient to turn towards your side, right? Turn towards your side and then give about 30 seconds and percuss and see, look for shifting dullness. If they are shifting dullness, you look for a fluid thrill. Fluid thrill, you ask the mother to keep the hand like this and you keep one hand on this side and tap on the other side to look for a fluid thrill, right? Then there is the gross ascites. Right. To complete your examination, you will palpate for the inguinal lymph nodes. Since it's a mass, it can be a malignancy as well. So you have to complete by doing the lymph nodes. And if it is malignancy, you will say, I want to palpate for the supraclavicular node. If you have not done the general examination, you have done the general examination, you have to look for that as well. What is the other system you have to assess? You have to assess the lungs. Right? Lungs should be assessed for pleural effusions. Okay, so you have to percuss the lung and auscultate as well. So that concludes abdominal examination. Okay. If there is a large mass which is arising from the pelvis, one more thing you can do is you can percuss above the mass to see if you can't clearly demarcate the mass. Now here I said that it's 20 week size. Why? Because I can clearly note the upper margin. But if you can't note the upper margin, the next step is you can percuss and see where the dullness begins. So it begins here. See? Resonant, dull. This is dull. Can you hear? This is resonant. Right? Then this is dull. So this is dull. That way also you can identify the margin. Then you, while percussing, you will see if there is any resonance on the mass. If there is resonance, there are resonant bands and off bands on top of the mass. So that means the mass is arising posteriorly. Bowels are overlying the mass. But here there is no such thing. Right? So that concludes the examination. Okay. So surgical gynae abdomen, auscultation is not necessary because we don't look for bruise on these masses that we get. But for surgical abdomen, you have to do auscultation 2 centimeters above and lateral to the above the umbilicus, lateral to the midline. You have to auscultate for renal artery bruise, right? And if you want to check for bowel sounds also, you can do. Gynae vertex not necessary. You don't do auscultation.